Neha, and we have with us Dr. Bindu, who is our president, and we'll begin with our third session today for liver disorders in pregnancy. So, a very warm welcome to all of you. And we will first begin with our panel discussion because of a slight change in schedule. So the panel discussion consists of three or four case scenarios, and we have with us our esteemed panel. We have Dr. Satish Kulkarni, sir, Dr. Purushottam Vashisht, will join us soon, Dr. Charita Pradhan, and Dr. Shrikant Tiwari will also be joining us soon. So, Dr. Satish Kulkarni, are you there, sir?
Yeah, I'm there.
Okay, welcome to you, sir. Sir is
Thank you.
a very senior gastroenterologist in Navi Mumbai at MGM, and we are really uh, privileged to have you with us, sir, today. We have with us Dr. Charita. She is a surgeon, robotic surgeon, laparoscopic surgeon, and she has been handling a lot of our complicated surgical cases at Apollo. Very warm welcome to you too.
Thank you so much. Thank you.
Okay. We have also logged in Dr. Jyoti Bobe, madam. She is our past president and has been guiding us throughout this academic year. Welcome to you, ma'am. Are you there? Okay. So we will begin with the first case scenario. This clinical case scenario consists of a 32-year-old, second gravida, and having one previous child. She is 15 weeks, 3 days today. She has had a previous normal delivery, and she is otherwise a low-risk mother. She has presented to the ER with multiple episodes of vomiting in the last 24 hours, severe abdominal pain, more in the upper abdomen. She has not opened her bowel in the last 2 days. She does not have any pervaginal bleeding or discharge. Off the record, we have also noted that her obstetric examination at this point of time has been normal. Her ultrasound does not show any abnormality within the fetus. The fetal heart rate is perfectly normal and there is no intrauterine bleeding. So my question here, I think Dr. Satish sir, you can take it up. We are still waiting for Dr. Purushottam to join. So being in the ER, going ahead with a patient who has severe abdominal pain, what are the characteristics or patient symptoms that should alert us obstetricians of non-obstetric origin of pain? That is my first question towards you, sir.
So it depends on the clinical characteristic of the pain, whether it is upper abdomen or lower abdomen, and what are the associated symptoms. Now, this second trimester of pregnancy, second trimester usually don't expect much obstetric complaints as such. Uh, Whatever symptoms that the patient has, if there is, food or meal related symptoms, they're more likely to be non-obstetric rather than obstetric. And if the pain is associated with, change in whether there is some discharge or vaginal bleeding, you can think of obstetric causes. Along with the history, what you find on examination also would matter. And depending on the examination of the per abdominal findings, where the location of the tenderness or where the location of the pain is, you can think whether it is obstetric or non-obstetric.
Dr. Charita, madam, is anything else in particular you would like to add?
No, I think Sir has very explicitly explained that it is important to delineate the character of the pain and the abdominal signs, basically, whether there is any peritonism or no peritonism.
Okay, because we come across such patients quite often. Usually, we see cases of gastroenteritis or gastritis, which is related to nausea or vomiting of pregnancy. So clinically, yes, we have ultrasound, we have other parameters to look into. So clinically, tenderness is the one point that we are looking at. It is very particular about a non-obstetric cause of pain. Am I correct?
Yes, absolutely. Signs of peritonism. Once you have signs of peritonism, no obstetric sort of vague pain will give you peritonism, isn't it?
Okay, okay. So by peritonism, you mean reflex tenderness and rebound tenderness. That is what.
Yes, that's right.
Okay, sure. Thank you, ma'am. Now, at the same time, what is the first line of management that we would go ahead for such a patient when she arrives in the ER and or in the antenatal OPD? So we are assuming that she's already on either doxylamine or ondansetron for her nausea and vomiting in pregnancy, which is very likely she's already on, may or may not be associated with some antacids. So she might be on either a syrup or she might be on a proton pump inhibitor also. So other than what she's been taken orally, has been already taking orally, what should be our first line of management? We are looking at such a patient.
So that would depend upon what you're thinking of. First is the relief of pain. One has to give some kind of pain relief to the patient because that is the predominant complaint. So intravenous paracetamol is pretty safe in pregnancy, and one can give that. One can give Buscopan if the patient has a kind of spastic kind of pain. If the patient has fever, tachycardia, and like Dr. Charita said, peritonism, then one should look whether there is an associated infective cause or not. And in that case, maybe a broad spectrum antibiotic which covers most of the bacteria, gram-negative infection within the abdomen will have to be thought of. And then, of course, we will evaluate this patient. If the patient is associated very dehydrated, then intravenous fluids and hydration also, have to be started along with this.
So bilious vomiting is one thing that we do not really see in early pregnancy. So that particular symptom, is it a warning sign in any way, or does it add to our
So bilious
clinical
vomiting would definitely indicate that this is a non-obstructive cause. Then one
Hmm.
has to see whether this bilious vomiting is secondary to an outlet obstruction or bowel disease or any biliary pancreatic disease.
Okay,
So then accordingly, the patient would be investigated further.
okay, okay. Thank you, sir. So, in order to understand why we see such cases in previously normal or patients not having any such previous history, is what are the predisposing conditions in pregnancy that increase the possibility of such GI complications? Like whether it is surgical or medical cause for non-obstetric GI complaints.
So as the pregnancy advances, first as the uterus kind of enlarges, you'll have some pressure on the small bowel, and that itself would lead to feeling of fullness, decreased appetite and satiety because of the fullness of the uterus. Constipation is very, very common associated with pregnancy. So many of these patients will be badly constipated, and then that sometimes may initially present with nausea and vomiting, and one has to relieve the patient of constipation. There are a lot of hormonal changes which come with pregnancy. Now, the hormonal changes will have its own effects, especially on the bile. It can make the bile more thick or what we call biliogenic, which can lead to precipitation of certain biliary disorders, especially gallstone disease in these patients. So then that will have to be evaluated and accordingly treated.
Okay.
Neha, Dr. Vashisht here.
Welcome, sir.
Yeah. No,
Okay.
along with this, suppose if the patient is also having history of, asymptomatic cholelithiasis, suppose patient has history of asymptomatic
Right.
cholelithiasis, then we should also think of, cholecystitis,
Hmm.
or patient is having past history of pancreatitis, biliary, you know. So in that case, we should also think. And suppose diabetes is there, and
Yes.
then these patients are definitely they mask the symptoms, so severity we cannot assess in diabetic patients despite having severe cholecystitis or appendicitis sometime. Appendicitis is also one of the thing which we can encounter during the pregnancy,
Right,
because
right.
the typical location will not be and presentation will not be very same because of the
Yes.
pregnancy.
Yes. So because of a pregnancy, an atypical presentation is very common, and we need to be on the alert for any other
Yeah, one more
causes.
thing. Actually, it could be because of progesterone also. Progesterone causes dilatation of gallbladder, as well as there is, in general, stasis of everything. So maybe that adds to it. And lastly, abnormality in the lipid profile. Maybe that is causing because of the hormonal changes that makes our patient more susceptible.
And like suppose patient is having history of asymptomatic cholelithiasis, we should also think of whether the stone has passed out to CBD. So it may be the biliary choledocholithiasis also. So it depends on the pain and how long the pain is persistent, whether coming and going, it is lasting more than 6 hours. So suggestive of any pancreatitis if it is really severe. So these are the few things we need to see.
Right, right. So a past history is important in
Yes.
all obstetric patients, even of having had asymptomatic any previous. Most patients will tell us whether they have had gallstones in the past. So that can be a key to understanding her history and understanding her symptoms at present. So now Dr. Satish sir took on the previous slide. So Dr. Purushottam. So what is the common diagnostic delay that you encounter when dealing with GI conditions in pregnant patients? So I'm sure you must have seen patients who have had these conditions and you have noticed some diagnostic delay. So where do you see that the challenge generally occurs?
No, actually, in pregnant patients, usually we avoid doing, so many tests like CT scan or so, which we can do in normally patients. So that is the diagnostic dilemma, that to avoid the X-ray and CT scan radiation. So mostly we should go clinically more. Depends on the, symptoms and signs and the past history. So this is the first thing. And suppose if the patient is having pain is very typical or severe, then we should not avoid, doing MRI or some imaging. So we should not delay. Suppose patient is having pain abdomen very severe, and that sonography is normal and examination is also normal, and we are thinking that it could be ischemia also, suppose, or some thrombosis. So we should do at least MRI with contrast, suspecting if it gives us some clue or not.
Okay, so refraining from diagnostic methods is not ideal. We must make sure that we are doing everything and doing the best for the patient at that time, even if it entails doing some advanced radiological testing. Yeah, am I correct?
They can do
Yes.
CT scan in exceptional cases also, because the radiation exposure is around 25 milligauss. So it is well within the safer limit. We should avoid prolonged exposure, but in second trimester, if it is required, then considering mother's health, we can go ahead with CT scan also in exceptional case.
Yeah, exceptional cases would be, I think, when we are thinking of terminating pregnancy. We are not thinking about the fetus. Then those cases like uterine rupture, you are suspecting, like then, I mean, you have to do, CT scan when we are not thinking of fetus
Your
radiation.
clinical impression also matters. If you're
Yes,
thinking of more of biliary disease,
yes.
and you need a good ultrasonologist, because he should not get distracted by the pregnancy findings on ultrasound. He should concentrate on finding the cause of his pain. Many
Mhm.
times, the patient may have a single stone which may come down into the bile duct, which may be missed on the ultrasound. So
Hmm.
if you have pain and you're clinically suspecting biliary disease, and if your liver enzymes are high, this
Hmm.
patient, then you should go ahead and do a MRI. So
Yeah,
one should be open for further investigation depending on the clinical situation also.
true.
So other than pain relief and our IV fluids and antiemetics and analgesics, what other medical management can we initiate in patients? So
See, management depends on what we are having differential diagnosis after history and
right.
examination. So everything depends on that. If we are suspecting dyspepsia or like symptoms are there, heartburn, reflux, epigastric pain, not very severe pain, we are thinking about only the mild erosive gastritis or some reflux. We can give PPI IV because sometimes oral PPI doesn't work. and IV PPI works well sometime. And if we are thinking biliary, then antispasmodic medicines are helpful. And depends on what we are getting in investigations. If the counts are high, like sir said, LFT is deranged, we are thinking choledocholitis or cholecystitis, or so then in that case, antibiotic is helpful. So depends on what are the differential diagnosis after the history and examination that drives us our treatment part.
If antibiotics have to be started, any particular choice of antibiotics, sir?
See, always penicillin augmentin is the safest. I mean, amoxicillin or ampicillin. These are the safest antibiotics we use normally.
Okay. So cephalosporin and that group would be preferred. Okay.
Yeah.
Now, just a minute. Right. So, just to reiterate what we all have discussed till now. So, when we are discussing going ahead with a presumptive diagnosis of cholecystitis, she will have severe colicky pain, which is localized to right hypochondrium, radiating to the right back or right scapula, may or may not have history of similar episodes in the past. Important thing is that fever may not be always present when there is cholecystitis, or it may present late. And Murphy's sign, or the typical sign of pain on inhalation in the right hypochondrium, that may not be positive in pregnancy, is what we need to all understand, because of the distended uterus and because of the change in the anatomy internally, such signs may or may not be positive. So investigations, we have to do our blood investigations, liver enzymes, liver parameters. Serum alpha fetoprotein will be misleading, which we see day in and day out. And what can be misleading from an obstetric point of view is that there is a physiological hyperleukocytosis, even up to 17 or 18 or 20,000 per microliter that we see. So that we have to take into account when interpreting our CBC. CRPS will be more accurate. And radiologically, Dr. Charita, is there something, a particular warning sign that you would go in more in favor of cholecystitis, because gallbladder sludge or even distended gallbladders are as such quite common in pregnancy also?
Yes, you're very right, Neha. Radiology, unfortunately, shows changes of acute cholecystitis at least 24 to 48 hours later after the process has started. Clinically, you pick up cholecystitis with tenderness much sooner, and this we have, correlated multiple times and had multiple discussion with radiologists, saying that you didn't say it was cholecystitis, but I went in, the gallbladder was thickened and there was edema. So ultrasound picks up cholecystitis, I think at least a couple of days after the process has set in. So it's a bit misleading for that. Clinically, I think severe pain lasting for more than 6 hours and continuous pain goes more in favor of cholecystitis. So you can assume the process of cholecystitis has already started then. As you said, WBC count is not reliable in pregnancy, as you can have your physiological leukocytosis. But CRP is again a good indicator. So in biliary colic, you will not get a raised CRP. But if cholecystitis has set in, then you will definitely get a raised CRP. So that would be more accurate than just ultrasound findings. If you get a thick walled gallbladder on ultrasound, it means that it has been going on for at least 2 to 3 days. Secondly, if you start getting things like air in the wall, foci of air in the wall of the gallbladder, that is a very worrying sign, which means you're going more in favor of severe cholecystitis or,
Gangrenous
gallbladder necrosis and gangrene. Yes.
Okay. Thank you, madam. Now, next.
Normally, we should also ask a radiologist to comment on gallbladder wall thickness. As normal person, as without pregnancy also, we take 4 millimeter at the cutoff.
Okay.
If it is more than 4 mm thickness, the chances of cholecystitis are very high, even without normal, I mean, in the normal circumstances. So that we should ask for is if we are thinking cholecystitis, if they say, because most of the time they do not comment properly.
Okay. Okay. Yes, we'll keep that in mind, sir. So, for Dr. Jyoti, madam, so when we have a case of cholecystitis, once we have reached a diagnosis, what obstetric complications must we anticipate in this pregnancy? And what preventive measures must we take for minimizing the possibility of these complications?
We can divide this into fetal complications and maternal. Usually, fetal complications will be preterm labor, which is more worrisome, then premature rupture of membrane, preterm delivery. In early pregnancy, there could be miscarriage. Then chances of stillbirth is very high. And lastly, fetal distress. These are the fetal complications. And maternal complications will be because of the complications of cholecystitis. If it is not diagnosed early, not treated early, the chances of gallbladder rupture, infection, sepsis, pancreatitis, and maybe multiple organ dysfunction syndrome. All this can occur. And preventive measures should be whenever we get a patient with high BMI or any patient who has taken treatment, IVF treatment, or maybe there are some other comorbidities, then we can start with basic things like lifestyle modification, good dietary advice. We can warn our patient about what are the warning symptoms, and in case of patients with asymptomatic GB calculi, we can guide them about the symptoms, and maybe regular monitoring we can do, and we can explain them what is it. And lastly, patients with GDM, we have to do regular triglyceride levels. And in such patient, I involve either hepatologist or maybe sometimes diabetologist. And as a group, we treat this patient, because if she comes with some complications, there will be a problem. And
Thank you.
lastly, early diagnosis. That is the most thing. The moment she comes to you, best way will be early diagnosis and faster treatment. That will reduce the risk of complications.
Okay, okay. Thank you so much, ma'am. So our choice of for preventing sepsis, we have discussed about starting a broad spectrum antibiotic, one with good biliary excretion. So a cephalosporin group generally works. If possible, we can do a blood culture if she is if she warrants that. Is there any role for biliary culture, Dr. Satish sir?
One more thing, can we add metronidazole to these patients? Because we are speaking about ceftriaxone, but are we supposed to add metronidazole also? I want to know.
Usually, metronidazole is not needed in biliary
Okay.
infections because usually they are gram negative. There's no anaerobic there. As far as culture goes, if you have to do, you have to do a blood culture. For bile culture, we may have to do either a ERCP and get bile or collect duodenal bile, which will have a lot of other flora. So it may not actually help you. Or if you're going ahead and doing a percutaneous cholecystostomy as a temporizing measure for a calculus cholecystitis, maybe at that time you can send the bile for culture and then kind of refine your antibiotic coverage according to the culture. But usually, if you want, you should do blood culture. Bile culture is not done usually.
Okay. And tocolytic cover will be required by this patient. So, madam, what will be our choice of tocolytic?
Actually, I will prefer nifedipine in such patients. Or maybe if she is in active preterm labor, then atosiban, because progesterone is not helpful considering liver inflammation, and it may not give good result as anticipated.
And it will, if it will worsen the
It will
biliary
worsen,
stasis and other GI parameters.
Even magnesium sulfate is also not very useful in such patients. It is better to use either nifedipine or atosiban.
Okay. So, in patients who have cholecystitis and we are managing them conservatively, there has been a documented increased probability of its recurrence again in the pregnancy, because the primary causative factor, which is the pregnancy itself, does not get alleviated till delivery, and there is a distinct possibility that it might recur again. So, Dr. Charita, what is your opinion or decision when it comes to decision about operating on during cholecystitis or cholelithiasis related colicky pain?
So definitely biliary colic, we would continue with conservative management and not take a risk of operating unless, there is something like choledocholithiasis wherein we could do an ERCP, a less invasive procedure and, just remove the stones and stent it. When it comes to cholecystitis, I think there are very clear-cut guidelines. If you see the SAGES guidelines, if you see the NICE guidelines, all of them, mind you, being Western guidelines, they suggest that laparoscopic cholecystectomy is safe, effective, and should be done if a patient presents with acute cholecystitis. Now, in India, that is not really very practical, as well as, a lot of patients will not be ready for surgery if you tell them straight away. So, what is a good guideline for us is, I think, if you classify cholecystitis as mild, moderate, and severe, according to the Tokyo guidelines, wherein mild is the cholecystitis that's limited to the gallbladder. Moderate is when you have associated raised counts and raised CRP and raised transaminases, and severe being where you have other organs involved, like acute kidney injury, bordering to sepsis, basically. And then restrict to your laparoscopic cholecystectomy for the moderate and severe cases, and treat the mild cases conservatively. Then I think that works, and it is patients are more comfortable with that. Because if a patient comes with mild symptoms in your first or second trimester and you tell them straight away about surgery, definitely more than the patient, I'm sure the obstetricians also would be the first people to object, saying, oh, can we not try with conservative management? So for mild cases, definitely conservative management should be the way to go forward. If you see the literature, there are various studies which are mostly cohort based and retrospective studies. There is no prospective study on this. But most of the studies are retrospective over a period of 10 years with around 10,000 patients. So a good number. And other than there being no randomization in those studies, all those studies have shown that lap cholecystectomy is safe in all trimesters of pregnancy. And the risk of preterm labor and other associated adverse pregnancy complications are much higher with conservative management. So the problem comes about, it's not just, yes, can we operate? Yes, according to literature, it is safe to operate. But I think there has to be a discussion between the obstetrician, the relatives, and the surgeon as to what risk the obstetrician is ready to take and the relatives are ready to take, and give them a clear idea about, what is the risk of preterm labor if we operate and if we do not operate, and then come to a consensus.
So, what is your threshold of gestational age when you would go ahead?
So
before
definitely
surgery
second
completion?
trimester is obviously the best time to intervene, because the uterus is at the level of umbilicus, but there is still some space above to go. Third trimester doing a lap chole is really, really difficult. So even the literature, a lot of case reports, they have said that in the third trimester, we should try and defer it till the patient, delivers, if possible. Again, if you are talking about severe cholecystitis, then we don't have a choice, because this patient has come with multi-organ dysfunction, and then it is risky for the both the mother as well as the baby to continue with conservative management. But second trimester is the best time. But even in first trimester, it is considered a relatively safe procedure. And if you see the literature, the risk of fetal loss is not as high as we would think.
And what is your timing for surgery? Would you go ahead with surgery during an acute episode, or you are waiting for it to, and then you give a break of maybe a
No.
week?
No, we always prefer between the first 7 days to go ahead and remove the gallbladder, because within the first 7 days, the surgical procedure itself is pretty straightforward. If you wait for more than 7 days, then you have to wait for a good 2 to 3 weeks or 4 weeks for the whole inflammation to settle down and not go into a fibrotic callous triangle. So either you operate within the first 7 days. So it's the same as a non-pregnant patient, really. So operate as soon as possible within the first 7 days. Otherwise, you have to wait for at least 6 to 8 weeks. Which again, given the timing of pregnancy, the timing of the stage of pregnancy, it's difficult to manage that in a pregnant female, isn't it?
Difficult to plan either that what
Yes, exactly.
happen ahead. Okay. So I think we have covered a lot of these next questions, highest gestational age, and yeah. So any special modifications that we make to the surgery or the process of surgery, the positioning, anything like that that we need to know, or maybe jointly explain to a future patient?
Yeah, so basically, left lateral tilt is useful because it takes the pressure of the gravid uterus off the IVC. As we are insufflating, there will already be some pressure on the IVC. So we can give a left lateral tilt and decrease that pressure by shifting the gravid uterus. A head up position also will, push the uterus down slightly and create a bit more space and open up our callus area. Pneumoperitoneum, we should again try and stay at a lower pneumoperitoneum, 10 to 12 mm, so that, again, for the same reason, we don't put a lot of pressure on the uterine blood flow as well as the IVC. And port placement, definitely avoid varies and blind sharp port insertions. It's best to do a Hassan's technique, wherein you do a open safe port insertion with a blunt
blunt probe.
trocar. And usually in lap colis, we go below the umbilicus, whereas anywhere up to the second trimester, we will still have to go above the umbilicus, because feel for the uterus, mark the level of the uterus, and go above that.
Thank you. So a few visuals about this. So the port placement, yes, like you mentioned, is going to be higher and maybe a little bit more lateral or in the epigastric region. And yes, the visibility of the gallbladder and the intervening small bowel and all these are going to be challenges during the surgery, but which may, of course, have to be overcome at that time. So another question, if a patient has been managed medically somehow throughout her pregnancy, a case of cholecystitis, she did not require surgery or was not willing, either way. When do we operate so do we go ahead with surgery in the postpartum period in such a patient if willing? That because postpartum cholecystitis is also a well-known entity, even in those who have not had a previous history. So in postpartum period, when is the earliest you can?
So if the cholecystitis has completely settled down, I wouldn't go in before 3 months. For the simple reason is that we wait for the uterus to shrink, for the vascularity to go down inside the abdomen, and then do like an elective cholecystectomy in this patient. Obviously, if the patient presents to us in acute cholecystitis, then we don't wait. We go ahead and do it as routinely within the first 7 days of the attack. But if the patient is completely settled, then yes, we would wait for 3 months for the uterus to go down, so that, we have enough space and less vascularity to go in for the surgery.
Thank you. Thank you. So let's go ahead with our clinical
Neha,
scenario.
one point
Yes.
is also missed here. I mean, because we are talking about the plain cholecystitis.
Yes.
And sometimes what happens is there is a small stone in CBD also. Sometimes there is mild pancreatitis also, some patients. But we manage
Yes.
them conservatively. But suppose if the bile duct stone is showing a small stone, LFT was drained, so we do ERCP, we put a stent there. then we are safe that this patient will not have any chances of biliary obstruction in the future, or in the pregnancy, during pregnancy, or she will not have pancreatitis also, because if the LFT is range, its ABD is showing stone, then it is better to do ERCP and put a stent. And if we manage cholecystitis with antibiotics, it's good enough. Then we can wait. So this situation also comes in clinical practice.
So, what are the challenges that we see during such ERCP and such procedures? in
Only thing is
pregnancy?
that we avoid doing ERCP in first trimester unless it is really required on third trimester. If it is, like second trimester, it is safer.
But it is
And
always under fluoroscopic guidance, isn't it?
yeah, but there are lead shields are there. We use them below the patients, when they lie down, we put the lead shields and we cover the, uterus, and we just make very, very small exposure of, and sometimes we can avoid also taking help of fluoroscopy, because when we put the cannulation, if the bile is there in the ERCP cannula, we know we are in the bile duct and we can put the stent also if only the stent placement is required.
Okay, so our
So there
clinical
are ways. There
expertise
are ways, yes, to do.
can bypass the
Yes, yes.
radiation
Yes, yes.
requirement also. Okay, that is a very good point, sir. So, okay. So now with our second clinical scenario, this lady is a 38-year-old primi gravida. She has a twin gestation IVF pregnancy and her gestational age is 24 weeks. She presented to the ER with fever for the last 2 days, which is low grade associated with malaise. She has epigastric pain, which is radiating to the back, and she has vomiting 2 or 3 episodes. Now, antenatally, she has gestational diabetes. She's on diet and metformin. She has pre-gestational hypertension, and that is managed on labetalol, 100 milligram twice a day. So, such a scenario is very, very common for us obstetricians these days, especially working in tertiary quaternary centers where multiple gestations, infertility, elderly, primi gravida is a day-to-day occurrence. It is not once in a while. So, in such a patient, when we see that on examination she's obese, and at that time when she's come in the ER, she's tachycardic. Her BP is within control, but she has a low-grade fever of 104. But her pain score is very high of 8 to 9. Along with that, she has tachypnea. She has shallow breathing, maybe due to the epigastric pain. And her uterus is 28 weeks. Both fetal hearts are audible. And there is no obvious uterine contraction, no obvious vaginal bleeding. So when we are looking at this kind of a patient, what are the differentials that we see from non-obstetric point of view, and a few pointers to all of you actually, to how do we differentiate among all of them?
See, Doctor, this severe gastritis, very unlikely patient is having fever, unless something infective component is there. And cholecystitis, definitely chances are there. Pancreatitis are there. Gastroenteritis usually doesn't present with epigastric pain. Normally, they come with periumbilical pain, colicky. The epigastric pain is typical origin of duodeноgastric origin. So, MI, yes, possibilities are there. There are, why not? If the epigastric pain is there, again, fever is little bit, offbeat. Pyelonephritis, quite possible. We do see pyelonephritis presents with fever and vomiting persistent normally, and pain also. For obstetric complications, I mean, preeclampsia, if she's known hypertensive, in the pregnancy period, already she has labetalol, she's taking medicines, and help also. There are chances.
Right. So
We also think of acute viral hepatitis also in such cases also, because when the mild fever is there, vomiting is there, sometimes they have pain also. So we should also think of viral hepatitis.
okay. So, Dr. Satish sir, Dr. Purushottam, so if such a patient having epigastric pain and vomiting, So we are thinking of GI symptoms and GI cause already. What are the typical clinical symptoms or markers that will help us differentiate whether it is cholecystitis or something much more lethal like pancreatitis? What would make
So,
us differentiate between the two?
so clinically, a pancreatitis patient would be, of course, much more sicker. This patient has tachycardia, shallow breathing, and she is dehydrated. Into pancreatic enzyme levels, in pancreatitis, you will get enzyme amylase and lipase levels definitely much higher than at least 2 to 3 times upper limit of normal. In simple cholecystitis without any bile duct stones, you'll get normal amylase and lipase. So that is how we will kind of differentiate. When you do evaluate these patients with ultrasound, obviously you can still see peripancreatic edema and evidence of pancreatitis there.
So, must we rule out pancreatitis in all suspected cholecystitis patients?
So if there is an alteration in LFT, then obviously one has to also look at the amylase and lipase. If you have simple pure cholecystitis, you don't need to, if there are no clinical signs suggesting of any severe, kind of pain and, hypotension or dehydration or tachycardia, in which case you need not.
So, a more systemic picture is what we see in pancreatitis, and a more localized
Yes,
picture is what
yes,
we see in cholecystitis.
yes,
Yes.
yes.
Okay, so that is an important pointer, sir. Now, in such acute patients, when they have a history of gallstones, so procedures like ERCP, cholangiogram, how often would that be helpful, and how often will that be needed in such acute patients?
So if you're a patient where there is clear-cut only cholecystitis with a normal liver function test and an undilated bile duct, on the ultrasound, I would not need a cholangiogram. If the patient has significant rise in her SGOT and SGPT, or if she has evidence of pancreatitis in the form of high amylase and lipase and gallstones, then I would need to know what is happening in the bile duct. In a pregnant state, I would prefer to get a cholangiogram done the non-invasive way. We would do a MRCP in these patients and have a look at the bile duct, and then take a decision whether we need to intervene and do a ERCP or something like that.
So MRCP will only be diagnostic, but it will help us, and ERCP will be both diagnostic and therapeutic if required at
The
that
ERCP
point.
nowadays is only therapeutic. We never do a diagnostic ERCP. For diagnostic purposes, we do MRCP. If there is a doubt, in certain cases, we may do an endoscopic ultrasound, but that would involve giving anesthesia to the patient, which again, we would not like to do. We would prefer to do a MRCP and have a look. MRCP will miss only stones which are less than 5 millimeters in size. So if the patient has a very strong suspicion as per the clinical indices that she has evidence of biliary obstruction, and if the MRCP doesn't show a stone, then we would go ahead, explaining the risks, discussing it with the patient, and then we would do a EUS. And if we find something in the bile duct, we do the ERCP in the same setting.
Okay. So, just reiterating all the diagnostic criteria when we are looking at pancreatitis, this is for my fellow obstetricians. So, the diagnostic criteria is 2 out of 3. So, there is epigastric pain that is radiating to the back, pancreatic amylase that is more than 3 times of the normal upper limit, and imaging studies which are favoring acute pancreatitis. So any 2 of 3 will give us a diagnosis, but the caveat being that pancreatic amylase may not rise for 48 to 72 hours, and radiology, as we all know very dearly, who is doing the ultrasound is most crucial in making the diagnosis. So, any pointers to that, anything you might want to add to this diagnostic criteria, or something that we must look out for when thinking of these diagnoses?
So amylase as well as lipase would need to be done. Just
Right.
amylase wouldn't be a diagnosis.
Actually, I was looking at the criteria. This is what I have seen in the from the diagnostic
Yeah.
the literature
Yes,
that I
yes.
read. But we do both of them, and both are helpful in making our diagnosis. And yes, but how so? Pancreatitis, is it easily picked up on ultrasound, or is it easily missed? Or
Neha, I think we should start looking at pancreas because we do obstetric ultrasound, but we never tried to go beyond uterus. So it is always better to look for spleen, liver, kidneys, how normal things look. Any kind of difference, definitely we can make out. And most of us are having very high-end ultrasound machines nowadays. So it is possible. At least we can suspect.
oh, so ma'am, by we you mean we should start?
Yeah, why not? See, if we have machine, definitely we can. Looking at IVC, aorta, means we should do that practice. We have a habit of seeing whatever is required. Like we will see the baby uterus, that's it. Or maybe ovaries, nothing else. So if we start looking at, maybe we will be able to appreciate what is normal and what is not normal. At least we can have that pointer. हाँ, he काहीतरी वेगळं आहे.
The
Ma'am,
pancreas is essentially a retroperitoneal organ. There is stomach and transverse
Sir,
colon
because
above.
it can be seen
So
very
even
nicely.
with the
I have,
even with the high-end ultrasound machine,
sir,
you
I
will
have
not be
started
able to
seeing it.
see a full of the pancreas. In fact, there are pancreatic diseases where we need beyond ultrasound, beyond MRI, right up to endoscopic ultrasound just to visualize the pancreas well. It's a very difficult organ to visualize. But yes, like you said, we need a good system to see. That is, the ultrasound machine has to be iron, and it has to be an experienced ultrasonologist who has
I agree.
time, who should not be in a hurry, who should look for changes of pancreatitis there.
Thank you.
no,
Yes.
I think one more thing is there, Neha, that any pregnant woman, at least one should have at least complete whole abdomen ultrasound at least once, minimum.
Very important point, sir, because that I am touching upon that further in the discussion that yes, because we see gallstones, they are asymptomatic, because we are seeing elderly patients, because we are seeing obese patients. So a thorough, like we have almost all of us have started doing a cardiac evaluation for all our pregnant patients before delivery. Same way, a GI evaluation for gallstones or other predisposing conditions in such high risk patient will go a long way in predicting or preventing such events.
Yes, totally agree.
So, there are predisposing factors that we are seeing these days. And like we just discussed, obesity is one very important factor. There very likely there could be history of alcohol use, and preventing that is quite easy. You have to abstain. Hypertriglyceridemia is a common factor. So, what would be if a patient, if we see an obese patient, Dr. Jyoti, madam, you mentioned that getting triglycerides done is essential. And how do we deal with that if a patient is known hypertriglyceridemic? What is our threshold? And what would be our advice for managing such a patient?
Actually, I just know that in pregnancy, triglyceride level will be high, but I have not managed such patient. Maybe familial hypertriglyceridemia patients, Dr. Satish or Dr. Vashisht can tell. I have not seen such patient.
Hypertriglyceridemia, pancreatitis, basically they have recurrent acute pancreatitis mostly. So we do manage with conservative management. Mostly they require hydration, as is the normal, pancreatitis patients, maintaining hydration and symptomatic treatment, mostly IV fluid and pain management. For if the triglyceride is too high, we do use, in some patients, um, this say insulin in some patients, but normally they do manage, they are managing, easily manageable by IV fluid therapy mostly. And then in the long term, to prevent the recurrent pancreatitis, they require triglyceride management, and mostly they are familial.
Mostly they are familial. Now, yes, patients come with history of gallstones. So, cholelithiasis is also a common cause for pancreatitis most often. So, there are factors which add to this, like first trimester dehydration related to nausea, vomiting of pregnancy, which causes thickening of bile, and hormonal factors which are also changing bile composition, associated insulin resistance of pregnancy, and progesterone related impaired GI motility and gallbladder contractility. So, investigations, yes, we have gone through all of them. Amylase lipase is the additional investigation. Electrolytes, because the importance being that it will have faster systemic effects and uh, lead to earlier sepsis and decompensation in the patient. So anything else that you would like to add to the initial investigation and evaluation in this patient?
No, I
And
think
if
we are
this is
sufficient. Yeah.
Yeah, and if this is proven pancreatitis, then along with the electrolytes, we need to know about the calcium levels.
Okay, okay. So, why is that an important factor? If you could elaborate, sir.
So in severe pancreatitis, we can get hypocalcemia that can have its own consequences. And sometimes, rarely, you can have hypercalcemia as a cause of the pancreatitis. So in any patient with severe pancreatitis, calcium levels will need to be monitored.
Okay, thank you. Now, what would be our management for pancreatitis in a pregnant woman? So, could you elaborate that, sir?
So the main management of any episode of acute pancreatitis is significant hydration. So in fact, the recommended is to give at least 200 to 250 ml of fluids per hour. So depending on the severity, we need to hydrate the patient well. We prefer Ringer's lactate or Caprolite solutions because they are more isotonic. We need to keep their electrolytes well. Antibiotics usually in a simple pancreatitis without much organ failure, I would initially avoid unless there is some evidence of localized sepsis, like if the patient has associated cholecystitis. But if during the course patient develops fever, or if the CRP goes up or the PCT goes up, or we are suspecting an infection, we would go ahead with antibiotics.
So
Preventing
pancreatitis is
antibiotics.
it's non-infective, it is inflammatory, not
Inflammatory. So the
infective.
first week of pancreatitis is more of a surge, and the initial treatment hovers around well hydration as well as maintaining electrolyte balance. If the patient has local ileus, then we need to kind of put in a Rice tube and drain out. If the patient is able to tolerate, then early feeding is better, and a good analgesia coverage.
Why
I
is
remember we had.
hydration the key, sir? If you could explain that.
So if you don't hydrate, then usually what happens in acute pancreatitis is that the pancreatic microcirculation is affected because of severe inflammation and edema. So if you maintain the hydration, you tend to prevent pancreatic necrosis, and we tend to prevent further progression to multi-organ. So the initial phase, the first 48 to 72 hours, very, very aggressive hydration is what is recommended. That is one which has shown to change the course of the disease. Lastly, about analgesia, I remember I had one patient who had come to us with very severe necrotizing pancreatitis during pregnancy, and the pain just wouldn't stop. And I remember once we had to go ahead and do an epidural injection. We put in epidural catheter, and we kept her pain-free during the entire episode. So sometimes you may have to go a bit, more aggressive for pain relief also. Nutrition also, the earlier resolution of nutrition orally is better. So if there is not much ileus, patient can tolerate orally, we start orally. If the patient has a lot of local ileus, nowadays we have special tubes we feed into the jejunum beyond the pancreas so that we can, start enteral nutrition early.
So,
And I think ERCP Purushottam has already spoken about. Yeah.
right. Now, this is a helpful flowchart that I have come across. when it comes to severe clinical symptoms which are suspected of pancreatitis. So, could you elaborate this for us for just for understanding if how our treatment plan changes, whether it is mild, moderate, or severe, and how do we differentiate between the two for our
So,
understanding?
there are a lot of scores where you can differentiate between acute, mild, moderate, and severe. But I'll make it very simple for you. If you have a pancreatitis which is associated with organ dysfunction, that is severe pancreatitis. If you have a pancreatitis which is not associated with organs dysfunction, it is usually not a severe pancreatitis. You can have various scores, but it is in clinical practice or in day-to-day practice very difficult to have those kind of scores, in the ICU and keep on mentioning all those scores. And all the scores have their disadvantages because they will reveal the actual severity sometimes at 48 hours, by which time you already missed the bus in therapy. Like I said, in the mild form, hydration, pain relief, and early institution of oral nutrition. In the severe form, again, severe, push towards a good hydration, maintaining electrolyte and calcium balance, pain relief, and we usually put in a jejunal tube and start early enteral feeding. We watch out for early signs of infection because many of these are necrotizing pancreatitis. So the second week onwards, they may get infection within the necrosis. So in which case, then you need to do a culture and then give antibiotics accordingly. Sometimes if there is a huge big walled of pancreatic collection because of the necrosis, then you may have to do either an endoscopic or a percutaneous kind of procedure to drain the infected necrotic material.
Now, Dr. Jyoti madam, we are looking at a lot of risks for related to pancreatitis in the fetus, like preterm labor, preterm birth, which will be managed similar to what we discussed for cholecystitis. There is a deadly complication which Dr. Satish sir also mentioned, which is SIR, systemic inflammatory response syndrome. So, what would be your take on that, or what uh, how do we go about with such a case?
Actually, because of systemic inflammatory response, there will be placental dysfunction. And the IUFDA risk is around 2.5 to 31.5% because the fetal mortality could be up to that range. And secondly, there could be associated sepsis because all this necrotic tissue may lead to transfer of bacteria from gut to bloodstream or directly to the uterus. And chances of chorioamnionitis are also very high. And lastly, because of pregnancy, there will be change in the immune response of the mother. As compared to non-pregnant patients, these patients are more susceptible. So even maternal complications are very high. So as compared to non-pregnant patients, these patients may go in multiple organ dysfunction rapidly.
Okay, thank you, ma'am. Now, Dr. Purushottam sir, chronic pancreatitis is a known entity. It is rare in pregnancy, but if a patient of chronic pancreatitis, how do we manage her during pregnancy? What would be the important points that we need to look into? Hello? Can you hear me? Hello?
He may have to unmute himself. I think he might be muted.
I am not muted. Dr. Satish sir, can you take over? I think Dr. Purushottam is logged out. I can't see him
Okay.
on the.
So chronic pancreatitis usually doesn't involve much risk to. But usually chronic pancreatitis patients might be malnourished. They have a lot of malabsorption associated. They may be diabetic and they may get recurrent episodes of pain. So if you can get, you may get an acute exacerbation of the pancreatitis during pregnancy, which may produce, whatever discussed before for acute pancreatitis. Otherwise, what we usually do is that if they have associated endocrine or exocrine insufficiency, then we add pancreatic enzymes to improve their fat digestion as well as manage their diabetes better.
Okay. So, as a conclusion, like what we have discussed about these two cases till now, so each mother with abdominal pain must be evaluated thoroughly. As obstetricians, we come across every OPD, we have at least one early pregnancy or second trimester mother who is suffering from nausea and vomiting and complaining of epigastric pain. It is quite possible that such a patient might have come for the second, third, fourth, multiple times. And we may dismiss her as being a case of only pregnancy related gastric pain. But a thorough abdominal evaluation, especially looking for tenderness and these signs, is very important, because a misdiagnosis can cost us dearly. Do not refrain from radiological evaluation early by a senior radiologist. Keep a low threshold for getting a gastroenterological opinion also in a patient who keeps returning to the OPD with complaints of upper abdominal pain. We must be on the lookout for history of predisposing factors like gallstones or hypertriglyceridemia, other risk factors like obesity, which will add to these the possibility of these conditions, and monitor such patients regularly. And if a patient has severe pain, getting a pancreatic enzymes done might be worth it, if not for diagnosing, but for ruling out pancreatitis, which is also just as important. Anything else that we would like to add before moving on to the next case?
I think that should be good.
Okay, thank you. So the third clinical scenario, she is a 26-year-old woman. She's married for the last 1 year. Husband has recently been detected to be HBV positive, hepatitis B positive, and reflex testing in her has diagnosed her to be positive now. She has come for preconceptional counseling. So a newly diagnosed patient with hepatitis B, what is our approach for this patient going ahead? What are we going to counsel her about?
So any patient who's yeah, I think Purushottam will take.
No, I think I was just thank you. This question was for obstetrician or us? For us. Actually.
We will eventually send to you. So,
Okay.
Yes, it is.
Okay. So, I mean, yeah, sir, Dr. Satishwar sir was saying something. Yeah.
And then I think you can go ahead, no problem. Yeah.
No, I mean, it's like, see, any patients with hepatitis B, like this is a normal person. I mean, we do evaluate when the patient is coming hepatitis B positive. We have to do certain tests to know whether this patient is having active hepatitis or this is just a inactive carrier. So in active carrier, we do HBe antigen, HBV DNA, and LFT. This will differentiate, and also fibroscan, just to differentiate whether the patient is suffering from chronic hepatitis or this is just an active carrier. So this will be the same evaluation for a patient who is having hepatitis B positive, which is incidentally detected without any symptoms. So question comes, they ask whether the pregnancy will be suitable or not. So it depends on, I mean, if the patient is having inactive carrier, in that case, we do not have any problem. We can evaluate the patient in between patient's status of hepatitis B DNA, whether it is increasing, and in third trimester, we can start the antiviral around 27, 28 weeks. Or if it is she is having chronic hepatitis, in those circumstances, we need to start medicines as soon as possible.
So
And these medicines
preconception
are safe.
counseling in such a patient, when do we, she wants to plan a pregnancy and she's aware that this is a transmissible infection. So when do we tell her that it's the best time to plan conception in a newly diagnosed patient?
See, I mean,
What are the parameters we are looking at a low viral
as I
load?
said, if it is low viral load, it is inactive carrier, then there is no problem because we are not going to start any medications. So they can start anytime because we don't have to start any medicine. We have to just start medicine only to prevent, infant infection, fetal infections during the third trimester. So there is not a problem. The problem is when the person is having chronic hepatitis and she is requiring medications, antiviral. In those circumstances, we have to tell them, the chances of hepatitis B infection depends on HBe antigen status also. So we start antiviral, bring the hepatitis B viral DNA in control, and then they plan. No, it's no problem. It's like a normal person.
Okay. So,
Anything else, Satish sir? I mean, if I missed something.
No. Yeah, absolutely.
Huh? Yeah.
Yeah.
Dr. Jyoti madam, what are the salient points that we are counseling her about? And her concern about transmission, her concern about how her pregnancy will progress, and the delivery also.
Actually, such patients are treated along with hepatologist or GI consultant so that they can be managed properly. From our point of view, we have to tell patient that there is chance of fetal-maternal transmission, but it is more at the time of delivery because of the exposure to all the body fluids as compared to transplacental. So that we have to explain her. We have to counsel her that she has to do monthly LFT. Plus, depending upon her viral load, she may need antiviral therapy. And she should be regular with her follow. These are the things which we are supposed to say. Secondly, we have to do additional co-testing because many of the viral infections are transmitted by the same route, like HIV, HCV. Then she has to be investigated for syphilis as well as chlamydia and gonorrhea because all these sexually transmitted diseases go hand in hand. So we should not concentrate only on hepatitis B. We have to think about other things.
Right. So, speaking about preconception counseling, yes, I came across some new things that during my reading. So, there is a mention of triple panel testing at initial prenatal visit for all patients who are coming in for. So, I wanted Dr. Satish sir or Dr. Purushottam to throw some light on this because we do a universal HBsAg screening for all prenatal patients. What is the significance of this guideline?
So according to this guideline, if somebody has not been tested ever before, they advise the triple panel where they look at the hepatitis B surface antigen, they look at the antibody to the surface antigen, and they look at what is called as a total core antibody to the hepatitis B core antigen. Now, HBsAg will tell us that patient has hepatitis B right now or not. But if HBsAg is negative and anti-HBs is positive, that means patient is immune either because of immunization before or previous infection from which she has recovered. In which case, if the patient has had previous infection, then the total anticore would be positive. And if it is a vaccine-related immunity, the total anticore will be negative. Sometimes you may have patients who have had previous exposure to the virus but are presently hepatitis B negative. So there will be total anticore antibody positive, but the HBsAg will be negative and the anti-HBs will be negative. Some of these patients may have what is called as occult Hep B, and that is where we need to look at their liver function, their fibroscan, and their viral load titers, and decide whether they have ongoing disease or not. So you are just being more careful by doing a triple panel so that you can select these kind of patients and act accordingly to prevent mother to child transmission, as well as if they need treatment for their liver disease, then we can treat it.
Okay. All women known to have an HBV infection prior to pregnancy, we have to do a repeat serology, including the HBE markers and HBV DNA for knowing her infectivity status at this point of time and going ahead. So, Dr. Jyoti madam, how often do we do a hepatitis C? Women are commonly vaccinated for hepatitis B with a good coverage in the community. So, do we check for hepatitis B immunity status in all patients antenatally?
Actually, we do HBsAg most often rather than doing antibody titer. Ideally, we should do antibody titer.
Yes, antibody titer. So, do you perform it routinely and recommend vaccination in women who have?
Yeah, I recommend vaccination. In fact, I give vaccination also. And ideally, we are supposed to repeat this test again in 28th week of pregnancy, in third trimester, at the beginning of third trimester.
For the vaccination.
Yes. For the vaccination as well as to know, to know the status. Because there is a chance that those who are not vaccinated, there is a chance that they can become firstly positive and pass on infection to baby.
Right, right. So, this is a short slide for the interpretation of hepatitis B, all the antigens that we do and the interpretation of the same. Dr. Satish sir, he explained it just now. And we need to differentiate between long-term carriers, immunized patients, recovered patients who have processed the infection and are no longer infective, and active hepatitis B infection when we are dealing with antenatal patients. Now, the next case scenario is a 28-year-old primary gravida. She's a healthcare worker. She's 8 weeks of gestation, and she is a known case of hepatitis B infection in the past. She has come referred to the ANC OPD and for review and for her antenatal plan. She is a long-term asymptomatic carrier. Her HBsAg is positive, HBe negative, HBV DNA is non-detectable. All these parameters of her last are at the time of her last evaluation done 6 months back at the time when she decided that she's planning conception. So what would be, she will continue as a routine antenatal with us anyways. In terms of her hepatitis B, what is the initial evaluation that will be recommended for this patient to know her infectivity status and the risks that are associated for her hepatitis B itself in pregnancy?
In this patient, now you have the reports which are pre-conception. So I would like to know what is the status now. I would like to know what is the liver function state, the LFT, and ultrasound of the abdomen, how the liver appears on ultrasound. And I would like to know a repeat hepatitis B viral DNA titer, because the titers may increase or decrease over a period of time depending on the immunity and the aggressiveness of the virus. These patients usually, see, if the patient has the hepatitis B chronic inflammation of the liver, pregnancy per se, we should not alter the disease as such, but we need to decide if she needs therapy, what drug to use, because we have to use a drug which is safe during pregnancy. And if the repeat HBV DNA is still very low, then she wouldn't need therapy, especially for LFT and ultrasound was normal, and the pregnancy can proceed as usual. Again, her viral load will need to be repeated in 28th week to determine what is the viral load at that time to prevent maternal to fetal transmission at the time of birth.
Okay. So, we are repeating her viral load at the time of registration and at 28 weeks and again before delivery. And if we are seeing any rise in that, then we will be starting her on antivirals. Is that correct?
Yes, yes.
So, the choice of antiviral will be?
So there are only 3 antivirals which are available for hepatitis B, out of which entecavir is not preferred because of not much data of safety during pregnancy. So we use tenofovir. There are 2 tenofovir molecules. Either of them can be used for treatment. They are very effective as well as no risk of any resistance, and they're safe during pregnancy.
Okay. Now, right. So, yeah, we covered most of this, and the monitoring also, I think we have covered all women newly diagnosed. Yes, we are doing a complete panel, and we are checking for other co-infections. and DNA testing at before 24 weeks and before delivery, and quantitative HbSAg testing for knowing her infectivity status. And when it comes to pregnancy and delivery, liver function tests, and these have to be monitored regularly, roughly every 4 to 6 weeks, I believe, in order to continue her maintenance. Is there any change in the immunological parameters that can lead to progression or worsening of hepatitis B infection in pregnancy?
Not that I'm very aware of per se. Yeah.
Okay. And if the patient is already requiring antiviral therapy prior to pregnancy, she will have to be switched over to
Yeah. So
tenofovir.
instead of entecavir, we would prefer tenofovir.
Tenofovir. So, when it comes to risk stratification of antenatal patients who have hepatitis B or who are recently diagnosed, which are the patients that we are most concerned about when it comes to the disease? Hello? Okay. I think Dr. Purushottam, are you there?
Hello. Yes, I'm there.
Yeah.
Hello.
Yeah. So
No, see, hepatitis per se, there is no issue. Because if the patient is suffering only from chronic hepatitis, there is no as such difference because we either she's on antiviral or we have to start antiviral later on. But person is having cirrhosis, that is a different issue. So that is a different discussion. So then we have to manage.
Other evaluations, do we need to add on, like you mentioned, a fibroscan, and if she has known cirrhosis related to that, so it would include screening for varices and other things.
Yeah, if suppose that we are evaluating a person, I mean, and fibroscan is showing reading more than 15 kilopascal, that means chances of cirrhosis are very high, and these patients should be screened for varices.
Okay, okay. Now, I think we have been through this already. That yeah. So, Dr. Jyoti, madam, what would be our delivery plan for this patient, and any particular intrapartum precautions that we are looking into?
Actually, such patients should be delivered in an institutional setup or maybe multidisciplinary setup. Even if you are delivering her in nursing home, other doctors should be involved. Then cesarean section or delivery will be as per the obstetric indication. Third thing, we have to wear protective gear like PP, shoe cover, protective goggle, double gloves, everything. Even the handling of waste, biomedical waste should be taken care of. In case of, we have to use sharp objects with care because chances of needle prick and injury is pretty high in such patients. Because of, I don't know, even I got exposed once. And in case of exposure, it is better to take post-exposure prophylaxis and notification should be given. Third thing, baby should be given immunoglobulin at birth as well as vaccination. And if in case of in case of exposure, even those medical professional or paramedical staff, whoever is exposed, should be given immunoglobulin as well as vaccination.
Okay.
I think baby's vaccination will be covered by Dr. Shrikant.
Yes, yes. So, any tendency to avoid an episiotomy if required, because
Whatever is necessary should be given. Only thing is that we have to take good precaution.
Right, for preventing baby exposure. Okay,
Yes, definitely.
right. So, Dr. Shrikant,
Yes.
hello and welcome. So, when it comes to neonatal management of babies of mothers who have hepatitis B, so what is the protocol that we follow?
So whenever the baby is born, we do the routine care, like we do for all the newborns, and after that we'll give the vaccinations, the hepatitis B vaccine, 0.5 ml on one thigh, and the hepatitis B immunoglobulin, which is around 100 international unit per ml that we give in other thigh. So the vaccination should be given immediately. If you don't have the immunoglobulin at that time, we should give that within 12 hours preferably. But still, if it's not available, then within 48 hours to 72 hours. So that is the main criteria. Like we should give both of them during the time of birth. So what we do here is we get a notification from the gynec that we are delivering such type of mothers, like the hepatitis HBCG positive mother. So we tell the pharmacy and we keep everything ready during the time of delivery, so that we don't have any problem in giving both of this.
So immunoglobulin availability is generally
Oh,
not
no,
an issue.
no, not an issue, not an issue. In an institutional setup, not an issue. We regularly get that, and we regularly get these types of patients, so we give them quite easily.
Okay. What is our breastfeeding policy
Mm,
for mothers?
It is, we should do breastfeeding as it is. Hello,
Yes, I'm right.
audible?
Yeah, yes, you are.
So as a normal routine baby, we continue breastfeeding, because as WHO says and other research papers also, that breastfeeding is not contraindicated in this type of patient.
Okay. Practically, when we are talking about transmission of hepatitis B, even with immunoglobulin use, even with low risk mothers with low
Yes.
hepatitis B load, transmission rates are still on the higher side when we are comparing it with other transmissible diseases like even HIV, where we have been able to bring it down well below 2%. When it comes to hepatitis B,
Yes.
even completely immunized babies, the transmission rate can be 3 to 13% is one thing that we have to make all mothers aware of. So, in such a
Yes.
case,
Yes.
what is the role of a specialist pediatric hepatology, or in the long term when we are looking at babies?
So what we generally practice here is, like, we give the first dose of hepatitis B vaccine at birth, and if this baby's weight is less than 2 kgs, we don't consider the birth weight at all, and we give that hepatitis B at 6, 10, 14 in a combination vaccine. We do the testing at around between 9 to 12 months of age, and if it's negative, we don't do anything. If your anti-HBsAg is positive, like the titers are very good, and HBsAg is negative, we still don't do. But if both are, like the HBsAg is positive during that time, then we refer to a pediatric gastroenterologist, and then we take it as a routine, like hepatitis and other positive cases like that.
So
So at birth, we don't yeah.
just 2 lines about the prognosis or long-term effects of neonatal hepatitis B.
No, so it's normally this goes into chronic carrier, and they become chronic carrier, and they have lot of problems. Like, for example, if we see a neonate, if the baby is not vaccinated or something is there, they will start showing symptom around 3 or 4 months of age, not before that. Jaundice, they will have persistent jaundice, E. coli excludes, they will have hepatomegaly, and generally we try to manage by giving supplementary treatment or vitamins and other things. But eventually they grow into chronic hepatitis, chronic and liver failure, and ultimately, if not getting managed, then goes for a liver transplant or other modality of treatment.
Okay, thanks. Now, yes, so this is what we have already gone through. So, infants in mothers who have HBe positive, anti-HB negative, a high viral load, and acute infection and low birth weight, they have a higher incidence of having infections having a persistent mother-to-child infection. What would be a policy for low birth weight babies who went to receive vaccination and
So for
immunoglobulin?
low birth weight, so we, in spite if it's baby less than 2 kg, we'll give the vaccination that time. But so normally the schedule is, in a normal unit, we give 3 doses of hepatitis B. normal schedule. But if the baby is less than 2 kgs, we'll give the vaccine at birth, but that we will not count as a birth dose.
And
We'll
immunoglobulin?
be giving to immunoglobulin, which we can give at any weight. The dose is standard dose, 100 international unit.
Okay. Thank you. Thank you. Now, just one, because hepatitis C infection is not that commonly seen. So, hepatitis C in pregnancy, Dr. Satish sir, Dr. Purushottam, if you could elaborate in short, because we are running a little late.
Hepatitis C is a very, very slow and indolent process. So if the patient is a non-cirrhotic patient, during pregnancy, we don't do anything for hepatitis C if the patient is diagnosed after the pregnancy onset. If we know that the patient already has hepatitis C and if it is possible, we can delay onset of pregnancy, then we treat and cure the hepatitis C with oral drugs and then ask patient to plan for pregnancy. If the patient is cirrhotic with hepatitis C, treatment is different, then maybe we may have to consider. Usually they will have significant infertility, very uncommon for a cirrhotic hep C to conceive. But if you do have such a case, then it's a very tricky situation because you need to treat the hepatitis C also for the liver. Most of the treatment for hepatitis C, the oral drugs are not allowed during pregnancy. So if you have a patient who's just incidentally hepatitis C positive, and say you're seeing her for the first time in first trimester, we would just wait for her to complete pregnancy if there is adequate liver reserve and treat her after pregnancy.
So, is there a progression of the condition related because
So
of
the progression in hepatitis C is over years. It doesn't occur in even in months. So
pregnancy
in
does not
this,
alter that? We see that a lot in renal
no,
disease and CKD, but
no,
chronic
no,
hepatitis pregnancy does not really alter the course of the disease. And mother to child transmission is
So mother to child transmission usually will occur in patients where the mother is hepatitis C and HIV positive. That is where there is a risk of transmission. Unfortunately, we don't have anything to prevent that kind of transmission. If the patient is just hepatitis C positive, irrespective of the viral load, hepatitis C virus is a very fragile virus. So the chance of it transmitting to the offspring is very less.
It is, sir, it will be around 5 to 6%, sir. If only the hepatitis HCV RNA is positive, sir.
Yeah, and nowadays the treatment with hepatitis C is so good that even if unfortunately a child does get an infection, the child can also be treated.
okay. And I think, yes, there are preterm delivery risks, maternal risks are there, and mother to child transmission, but there is higher incidence of fetal risks like low birth weight, and if associated with hepatic compensation, then related preterm birth, low birth weight, and these complications are commonly seen. Thank you, everybody. And I think we are at the end of our panel discussion today. Thank you, Dr. Purushottam, Dr. Satish sir, and Dr. Charita, Dr. Jyoti madam. Dr. Purushottam, are you with me?
Yeah.
Yeah,
Thank
so
you.
I think we will begin with our the first portion that we had deferred to the end of the case is a discussion of chronic liver disease and portal hypertension in pregnancy. So let me just begin with that slide share. Just give me a minute. Does anybody in the audience have any queries about this? About our previous discussion? Any queries that, or maybe some chat questions that I have missed looking into?
A little bit about the hepatitis E in pregnancy. Hepatitis E.
Hepatitis E in pregnancy.
Hepatitis E has a lot of risk during pregnancy. If you see routine hepatitis E leads to a kind of prolonged icteric illness with a small percentage, about 3 to 5% developing acute liver failure. But in pregnancy, the risk of developing liver cell failure is much high, as much as 20%. Nowadays, we have a vaccine which is available for hepatitis E, and there are indications that you may vaccinate the lady before pregnancy to kind of prevent hepatitis E during pregnancy, only because the risks of hepatitis E during pregnancy are very high. I think that's it about hepatitis E and pregnancy. Nowadays, we are seeing a change in the kind of acute hepatitis that we see in India. We are seeing more hepatitis A, and somehow we are not seeing as much hepatitis E as we used to see before.
What's the name of this vaccine?
There are two this thing. One is the Hevrivax and one is He-vaccine. And it is to be given in the same dosing schedule as hepatitis B, 0, 1, and 6.
Thank you so much.
Okay. Any other questions? Okay. So, Dr. Purushottam, sir, are you with me?
Yeah.
Okay, so let's begin our discussion about chronic liver disease and portal hypertension in pregnancy. So, before we dive into the slides, what is the incidence and how commonly do we see these conditions in our clinical setup or day to day? Other than, dedicated liver and hepatic centers, how often do we see these conditions in the community?
See, cirrhosis and pregnancy is not, unusual. We do see, but not very commonly, because nowadays they say, the detection rate has increased. We have FibroScan also, and monitoring is quite frequent, and so we do see, but uh, not as, common, but we encounter these patients in between. So data says out of 3,000 pregnancy, we do see one CLD patients normally. So this is
So
the frequency.
it is a common occurrence.
Yeah.
So welcome, sir, and let's go into the definition of chronic liver disease. And like we are seeing that there is an incidence and there is a significant morbidity and mortality that comes along with it.
So there, I will just simplify it, because most of the concern are basically not because of cirrhosis. Cirrhosis itself can make a pregnancy little risky, and if it is portal hypertension, then it is very risky, because if a person, suppose if it is not a pregnant patient, and this person is having cirrhosis without portal hypertension, so there is no problem much, because they are mostly asymptomatic. So this is known as the compensated cirrhosis. Everything is complicated in cirrhosis because of the portal hypertension. So portal hypertension is the problem in normal person and pregnant also. In pregnant, why it is serious? Because pregnancy, again, if a hyperdynamic situation, situation is there, where cardiac output is increased, and fluid retention is there. So this makes the portal hypertension more severe. So cirrhotic patients with portal hypertension is definitely requires attention in the pregnancy, unlike compensated cirrhosis.
Okay. So the complications associated with portal hypertension, mainly we are looking at varices and
when we see complication of portal hypertension means decompensation in terms of variceal bleeding, encephalopathy, and jaundice, along with bleeding risk. So decompensation means variceal bleeding is the most troublesome things which we encounter, and then some patients they have ascites and encephalopathy. These three things are, we have to manage during the pregnancy, and the most troublesome, as I said, variceal bleed. So we have to keep these patients under observation, and we have to screen for varices. As I said, if the person is having FibroScan reading is more than 15,
So these patients should be screened for varices if they are small, medium, or large. So that means whether they have any chances of bleeding or not.
Okay.
So if the
So,
person is having small varices, then there is not to worry. We can add beta blocker to such patients. If the patient is having high risk varices and with the signs of uh, impending rupture, like we say CRS, cherry red spots, and Redwell sign, then we need to bend them. So this is known as the endoscopic variceal ligation. So everything
so
depends on if it is which trimester we are seeing, or whether it is pre pregnancy, screening period.
So it is possible that these conditions are diagnosed in pregnancy.
Yes, yes. Sometimes because patient might be compensated cirrhosis, and we encounter patients having cirrhosis. So we need to screen them completely for varices and other factors.
So how it
Things become easier if we are finding everything when they are planning for pregnancy and we find cirrhosis in the lady. Then things are easier.
so how would a cirrhosis be diagnosed in pregnancy? By raised liver enzymes and or
No, cirrhosis basically usually doesn't have any symptom until unless portal hypertension is there normally. So portal hypertension means whether they have any fluid retention tendency like ascites, incidental finding of ascites and small shrunken liver in the ultrasound, or they have unusual edema in the feet, or they have unusual thrombocytopenia, which is not explained by the pregnancy condition, or if they have any variceal bleed.
so thrombocytopenia is one important point that you have.
Important thing, yes, which
Yes.
is normally pregnancy patients, they have little low platelet count, but if it is really unusual, then we should also think of something is
So
wrong.
before labeling a patient to have idiopathic thrombocytopenia or pregnancy related, we have to rule out liver related factors,
Yes.
and we have to screen the liver and spleen before deciding that it is just idiopathic or gestational thrombocytopenia.
Yes.
Okay. So that is one important take home for us because we see thrombocytopenia quite often. I think every other patient has platelets at least under 1.5 lakhs and maybe lower also. So many times our patients of gastritis or who have nausea, have severe nausea, vomiting of pregnancy, they do complain of blood in their vomiters. We do hear it often. So should that be alarming or the
No, I mean, see, variceal bleed is very torrential normally. So these patients, if they have hematemesis, it will not be like normal, hyperemesis gravidarum until unless patient is having malarious tear. So these patients have very torrential
okay,
bleed.
okay.
Mostly
So
they will have
we
hemodynamic
can't mistake it for
instability.
anything else.
Yeah, it is very hemodynamic instability is there. They will have melena, they will have orthostatic changes, postural symptoms, mostly if they bleed severely.
So, in patients of chronic liver disease who are coming for preconception counseling and fertility planning, so what are the conditions that make conception difficult for these patients, and what are the conditions that we need to correct before she plans conception?
See, conception, if the cirrhosis is there, it definitely makes the conception little difficult. These patients are mostly having amenorrhea. So depends on the severity of cirrhosis. 30 to 60% patients, they have amenorrhea, they have infertility, they have difficult to conceive. And when we evaluate, we find, some cirrhosis is there, or sometimes, we have to, monitor. I mean, mostly if the patient is having only compensated cirrhosis, then we need to do the hormonal test just to know what is the level of estrogen, FSH and LH, make the nutrition little better, because if they are malnourished, it is again one of the reason.
Even in a compensated cirrhotic patient or a compensated liver disease, will pregnancy lead to progression of the disease itself because of changes in the pressures and changes in the portal circulation?
See, decompensation can happen. I mean, they say, I mean, it is 10 to 15% chances are there that pregnancy might, you know, agree with the decompensation. Yes, but not very common, around 10 to 15%.
Okay, and who are the patients that we would advise against getting pregnant or classify as high risk when it comes to planning
Again,
pregnancy in chronic liver disease?
symptomatic chronic liver disease means symptomatic cirrhosis means they are having changes of portal hypertension, like ascites and swelling on the feet, you know, and as I said, these are the few things we will ask them. This will be a very difficult, you know, pregnancy, and if they have varices, high risk or medium risk, so these are the patients we will classify them very high risk pregnancy patient. So if they have pre-pregnancy, all these findings are there. They have to be very aware about the complications while getting pregnant.
Okay. Now, we see a lot of fertility issues or subfertility in patients who have liver conditions, mainly because of hormonal dysfunction. The HPO axis is disrupted. Most of our fertility, our reproductive hormones, they are processed in the liver. So there is differences in the ovulation. And like you mentioned, sir, there is amenorrhea, which in women with cirrhosis. So other conditions are also, it could be cirrhotic, non-cirrhotic, or autoimmune. So the management, is there any particular points or something that you would like to highlight about management of any particular these conditions, like inherited?
FLD, there is nothing, I mean, much because we don't have any medicines, so we have to weight management, lifestyle issue. Autoimmune hepatitis normally, I mean, doesn't affect, you know, any problem in the pregnancy. Although they say it, 1/3 of the pregnancy it flares, but it doesn't affect normally fertility issue. Wilson's definitely can cause miscarriages, as you have written. So if we find the Wilson disease is there, we can start the medicines. Exclusive zinc is the good treatment to start with. And suppose if they have, they are not pregnant, so we can start penicillin also. And after some time, we can switch over. We can continue this also. We have to manage the disease per se, you know, etiology. So if hepatitis B is there, you manage hepatitis B. Hepatitis C is there, you can manage hepatitis C. Wilson, you have to manage Wilson and autoimmune. So depends on the etiology and their treatment.
Okay, so in autoimmune hepatitis, we are relying on steroids and biologicals also. So many of these autoimmune, recombinant antibodies and these, they are not compatible with pregnancy, or they have not been tested enough. They are not biologics that we use.
Autoimmune hepatitis, if we already diagnosed before pregnancy, there is no problem. We can continue the medicines like steroid if the patient is having a steroid or azathioprine. We can continue these medicines. These medicines are usually safe, so they do not affect the fetus, and we can continue them, no problem.
Okay. Now, with the increasing advent of transplant medicine and transplant surgery, we are seeing unique cases of patients who have undergone transplantation of the liver and are now in the reproductive age and are conceiving. So any particular experiences or any special conditions that you would like to, elaborate about this, sir?
In pregnancy, what we have forgotten the use of medicine, you know, in such condition. Liver transplant requires immunosuppression. So first we need to choose, I mean, these patients as which medicine, suppose if the patient is on tacrolimus or if the patient is on mycophenolate or, these are the so few medicines we need to change before we go for pregnancy. Tacrolimus is the safest one, which is being used by the transplant surgeon and pathologist. Steroid and Azoran usually, steroid is only for short period. Azoran is basically not being used commonly. And some other medicines like mTOR inhibitor, they are also being tested and they are also being found helpful. Initially, they were thinking that they can create some issues. Again, some cyclosporin, again, we can switch over to tacrolimus. So certain medicines we have to adjust, first of all, if they are planning for pregnancy. And normal waiting period for pregnancy after transplantation, the safest is usually is 1 year, minimum 1 year, ideally is 2 years.
Ideally, 2 years, patient should be on, should not conceive immediately after.
Yeah.
Okay. And yes, we are seeing assisted reproductive technology being used after in women. It is a viable option. Surrogacy in unique situations where any of these are possible. We have discussed the medication safety and conception assessment. And antenatal monitoring. Yes, Dr. Jyoti, madam, are you here? I don't think so.
So antenatal monitoring, better. Nothing. I think you have to
Yes,
be
I'm
just
there.
little more
Actually,
frequent. Yeah.
Will you please repeat the question?
So, madam, about in chronic liver disease in pregnancy, any the antenatal monitoring or any unique experiences that you have seen during your practice when it comes to chronic liver diseases in patients who have conceived and who went successfully through their pregnancy and delivery?
I saw only one patient with Budd-Chiari syndrome, but that patient had thrombotic event and she lost the baby. It was like mid-trimester abortion. So no experience otherwise. That's it.
Okay. So, yes, when it comes to preconception counseling for such a patient with chronic liver disease, so when we are discussing with the patient about the possibility of varices and variceal related bleeding, what are the challenges that that you encounter when dealing with such conditions in pregnancy regarding to the procedure itself?
Procedure means endoscopy.
Yes.
See, any endoscopy in pregnancy is little risky, So mostly we prefer doing in second trimester, which is the safest one. So if the patient is having medium-sized varices, not very much high chances of bleeding, so we take these patients again during second trimester to have a look again whether the total hypertension has gone up. And if we find varices are risky and they have chances of bleeding, we should bend them. So repeat endoscopy is required during second trimester. One thing is that before we go further in the pregnancy. And if the patient is having small varices, then beta blocker is good enough. Nothing to be done.
Okay. Any particulars during delivery? So yes, obstetric management during delivery is not going to change. Any medications or any are oxytocics or we use prostaglandins routinely for augmentation. So any of these have to be avoided in pregnancy during the delivery?
I don't think so. I don't think there is any contraindication unless that drug is metabolized in liver. So maybe analgesics, we should be little cautious. And if permitted, we can go ahead with epidural also.
Okay. Right. So if the coagulation profile permits and if the platelet counts and all permit, then epidural analgesia will go in a long way in preventing a cesarean, I would say. And yes, we have to shorten the second stage of labor to avoid straining and diaphragmatic pressure and the risks associated with that. Yes, spontaneous abortion and miscarriages are a known complication in early pregnancy and mid-trimester. And yes, there is possibility of preterm birth also with any medical condition and associated pregnancy. Now, this is I think we have been through this slide again. And
Only one thing is that if the patient is having compensated cirrhosis, so then normal pregnancy can be, done, delivery, NVD.
normal
Only thing is
pregnancy
that
can be.
like normal vaginal delivery can be done, if the compensated cirrhosis is there. Only thing is that when the person is having incidental detection of decompensated cirrhosis, high grade varices, then we need to plan cesarean actually. Then it is difficult to take these patients as normal vaginal delivery.
Okay. So, like we discussed, so in chronic conditions, yes, mycophenolate mofetil is known, it is completely contraindicated. ACE inhibitors, which we are using for hypertension. Actually, I did not understand. Is methotrexate used in chronic CLD?
No, we don't use normally.
Not used.
Much.
Actually, it is not used.
Yes, okay. Now, yes, immunosuppressants like you mentioned, sir, prednisone and azathioprine and tacrolimus and hepatitis B tenofovir. And yes, UDCA we use regularly for cholestasis, and other treatments are very well compatible with pregnancy. Yes, obstetric complications when we are looking at, there is possibility of PPH. In liver conditions, we obstetricians very commonly come across with atonic
Yes.
PPH, and that is the dreaded complications, which sometimes goes beyond any medication that we can prescribe and becomes really challenging to manage at the time of delivery, because bilirubin and the jaundice itself has a atonic action on the myometrium. So, anything you would like to add to this, Dr. Jyoti Madam?
Actually, contraception. One baby is enough for such patients.
Mhm.
Yes, yes, we can advocate that to our patients. I agree. Now, fetal neonatal outcomes, yes, the threat is generally of preterm birth and low birth weight, and if delivered with a good backup, that should not be a problem for the baby. And each trimester, we have gone through what all other complications that we can expect. And yes, like the dreaded complication with Dr. Purushottam you have mentioned is that the variceal bleeding and portal hypertension, which is the real threat when it comes to continuation of the pregnancy. And yes, so this is one point that I would like you to elaborate on. Is there any requirement for a diagnostic scopy? How do we, when you mention screening for varices, is it endoscopic or is there any other way?
See, the new classification, what for portal hypertension is the Baveno classification 7. So nowadays we don't screen directly for varices. So before that, we have to do some non-invasive screening, which is the fibroscan and some blood scoring. So we find that fibroscan is reading is high, as I said, more than 15 kilopascal. Stiffness level is, this is for the liver stiffness median. If it is more than 15, then the chances of having varices are high. So we have to classify with non-invasive.
So the sequential screening, there is screening with the fibroscan, and then you, if high risk for varices.
And then scanning, and then for endoscopy.
Any role of transesophageal ultrasound?
No. Transesophageal ultrasound is not required. It is the same endoscopy. This is the same implication for endoscopy.
Okay.
So, yeah.
Okay. Yes, third trimester complications, there is, of course, possibility of ascites, and if decompensation of the liver occurs, then there is possibility of encephalopathy and other complications. And acute fatty liver, yes, that is the dreaded big thing that can happen. Now, postpartum flare-ups, should we anticipate in patients with?
This data is little high, but normally they say 30%. 30% they are remain silent, they are 30% flare. And autoimmune hepatitis, if the person is not being managed properly, they have more chances of flare. If they have stopped immunosuppression or some irregularity in medicine. Otherwise, 25, 1/4 or 1/3 patients, they might flare up. So we have to be little bit sure that they are taking medicines regularly. That is the most important thing.
And would varices preclude us from thinking
Yes,
of
as I
normal
said,
delivery?
As I said, if the patient is having decompensated CLD and on screening we find large varices with high risk, stigmata of variceal bleed, then we should not do with normal vaginal delivery. These patients should be, planned cesarean section.
Okay. Thank you so much, sir. Anything else that we have not been able to cover?
One thing we have missed is the theoretical risk of splenic artery, aneurysm rupture in pregnancy, which is being mentioned in the literature, although we have not seen in any patients yet. But they say these patients, they have CLD patients with decompensation and varices. Splenic artery, aneurysm rupture is quite seen in these patients. So we should be aware if any patient is hemodynamically unstable, pain abdomen, we should think of this entity also.
Okay. Thank you so much, sir. I think we have come to the end of our discussion today, and I would like to just bring our session to an end. Dr. Bindu, madam, anything you would like to add?
No, very elaborate and very nice job. Neha, you have done so much of reading and it has definitely improved and our academics definitely a lot. I think these were too much, 2-3 cases were too long for a discussion.
Yeah.
So some people have left. So maybe we'll take up cases sometime later. Okay, thank you very much. Thank you, Dr. Purushottam, Dr. Satish.
Thank you, Neha.
And
Thank
Dr.
you, thank
Jyoti
you,
also.
everybody.
Thank you very much. Thank you.
Thank
Neha.
you, sirs and madams, for being here.
Thank you, Dr. Purushottam. Thank you, Bindu, Neha.
Thank you. Yeah.
Enjoyed.
Thank you.
Thank you so much. I'll log off now.
Yeah, thank you.